It's Friday, May 22nd, 2020. This is the future path of the pandemic with Professor Kirk Smith, whom I will introduce in a moment. First, I want to thank Council Member George Eberstadt, who invited Professor Smith to speak with us. If you have a connection to a leader you think the Council should hear from, get in touch. Now, let me introduce Professor Smith, and he is impressive. He's a professor of global environmental health at the University of California, Berkeley, hence my peace t-shirt, as I was sharing with him moments ago. And he's director of the collaborative Clean Air Policy Center, Delhi, which is a new institution involving 3 major Indian universities and UC Berkeley. He's worked all over the world. He's worked in China, interestingly, since 1981, far before most people in the West visited, at least in the latter half of the 20th century, and India since 1978, even earlier. And is currently conducting field work in Mongolia and India. He's most known for his work on the scale of exposures and the resulting health impacts of air pollution from simple household cook fires, which Professor Smith pioneered with colleagues in India in the early 80s. This is really important work. It's had a huge impact, and the work has continued with field studies in India, Nepal, China, Laos, Mexico, Guatemala, Mongolia, Paraguay, and elsewhere. The risk that they identified is now recognized to cause as much or more ill health as any other environmental risk factor globally, partly through being a major contributor to outdoor air pollution. He's done a bunch of other things, monitoring devices for several aspects of air pollution exposure. He has conducted research on the health impacts of climate change. He's credited actually for development of the concept of co-benefits. This is an important concept, actions that achieve goals to reduce climate risk and also at the same time, importantly, promote health. He's written over 400 journal articles and other publications. He's been granted honorary professorships in universities in India, China, and Mongolia. He shared the 2007 Nobel Peace Prize as a member of the Intergovernmental Panel on Climate Change, IPCC, and was co-chair of the health chapter of the most recent IPCC 5th assessment. He's an elected member of the US National Academy of Sciences and was awarded the Heinz Prize in Environment and the Tyler Prize for Environmental Achievement. A number of you have submitted questions ahead of time, which Professor Smith and I have both reviewed and we will address during this talk. He will start by speaking for 15, 20, 30 minutes, and then we'll have a live Q&A. Professor Smith, thank you for so generously agreeing to come and be with us here today. There's still so much unknown about this virus and the path of this pandemic. As we were talking earlier, Brazil is now reputedly becoming the next hotspot with 900 deaths a day, and the mayor of Sao Paulo warning the city's health system could collapse in the next 2 weeks. It's really alarming. And of course, the US now has more than 95,000 deaths. We lead the world, which is not how we want to be seen, but the rate of deaths are slowing down, obviously. The economy is forecast to drop around a 40%, drop by a 40% annualized rate in Q2. And we're still getting, of course, millions of new weekly jobless claims. What can you tell us about how you think about this pandemic, and what kinds of possible future paths are we looking at here, you think?
Well, thank you for inviting me, and glad to be here. It's a huge set of problems you've laid out, and it can't, don't want to try to address them all. And if I knew all the answers, it would be, I wouldn't be here. I'd be somewhere else. But let me try to. I thought maybe I'd present a couple of recent studies that illustrate some of the important issues here that would be of interest to your audience. Yeah. So I'm going to try to share my screen here. Sorry. Can everybody see that?
Yeah. Do you mind clicking into the slideshow mode? It'll make it a little bit bigger for us. Down at the bottom of the screen, there's the little.
There we go. Yeah.
Perfect.
There we go. Okay.
Yeah, there we go. That's great.
So this is, the one modern country that had a big impact, or it had a big impact and, has a pretty good data collection system, is Italy, as you know. Just by luck of the draw, Italy got caught early by visitors from China. And this is some quite interesting material here. It shows the, there's the official death rate from COVID, and then there's the excess death rate compared to last year. And so and one would hope that the two would be close together, but actually, as you can see, the historical data, I mean, if we just take the upper left quadrant of one of the provinces or states in Italy, the COVID data don't come, are well above the historical data. So there's a huge impact on the health of the population. But if we move to the next slide, which compares in detail two states, Lombardia and Bergamo. Now these are entire states, provinces they're called in Italy. So if you look at the excess, the official excess of COVID deaths, that's across the ages going from left to right. And you notice that there's the difference between the excess deaths, that's the top line, and the official COVID deaths gets to be substantial. So by the time you get out to the oldest group, the 80 to 89-year-olds, the official COVID deaths were only 1/4 of the actual deaths that occurred. This is why epidemiologists are saying we're greatly underreporting. The 95,000 you quoted, that's the official deaths, but it's probably, don't know how much bigger, but it's much bigger than that. It's not 4 times bigger, but maybe for the oldest ages, because people die at home, they die of that apparent, and they in nursing homes and whatever, and they don't get good autopsies, they don't get tests, and so they're dead. Everybody's pretty good at keeping tracks of deaths, but we're not actually sure what they died of.
And but, I think people understand the notion of excess deaths, but could you just—
No, excess deaths at younger ages, on the other hand, are not too badly represented by the official COVID deaths, as you can see, but it gets worse with age. But the most interesting thing to me about this particular study, they took one of these provinces, Bergamo, where the belief is that 100% of the population was infected. Everybody had an infection. Now that's not a huge state. It's about 1.1 million people. And then they looked at the death record of that population, and a quite striking thing occurs, that the risk of dying from COVID is about equal to your natural risk of dying anyway. So for me, as somebody between 70 and 79, I have a 2.5% chance of dying this year just from other causes. And if I were to catch COVID, it would add another 2.5%. In other words, I would have a 5% chance of dying this year. And then next year, I would go back, presumably, to my natural, so to speak, risk of dying, although we don't really know what the long-term impacts of COVID infections are. So people who are infected may end up having a lower life expectancy for long periods of time, as it is with other diseases, but not knowing that. So, but somebody 80 to 89 who has a 6% chance of dying every year, they would have a 6% chance of dying of COVID also. So, this illustrates what we've all heard, but it quantifies a bit on what we've all heard, that the risk of mortality from this disease increases substantially with age. But interestingly enough, it goes at lower levels too. So if you're just 30 to 39 with only 1 in 10,000 chance of dying naturally, you would also increase your risk by 1 in 10,000. I mean, not very much. And so if the disease wasn't infected from person to person, then of course the younger groups wouldn't have to worry so much at all. I mean, or rather, better said, perhaps it doubles their natural background risk of death. Now, another way of looking at this is to say that if you are infected at any particular age, it's like suddenly becoming 10 years older. So for me, suddenly like becoming somebody in his early 80s. because my risk is doubled. So now this is, interesting thing that also if you're 60 to 69, suddenly becomes like you're 70, you live at somebody who's 70 to 79 for a year, and then you go back to being 60 to 69. So now this, of course, is averages. It's not individuals with their own particular risk factors like smoking or, existing chronic disease like heart disease or diabetes and so forth. These are averages. And this is for the Italian system. Now, Italy, the average Italian has a 5-year better life expectancy than the average American. And so these numbers are probably bigger here because our risks at each of these ages are greater than the average Italian. On the other hand, this occurred during the time in which the healthcare system in Italy was being overwhelmed. And so perhaps people were dying at greater rates because they got sick and the healthcare system couldn't handle it at the time, which is the risk that, of course, we've been focusing on a lot in this country, at least up until recently. So this, lays out a sort of quantitative structure, and this kind of analysis has been done in several other countries now, and it looks, roughly valid in a number of countries. Is how this, in some ways, odd disease acts in the population. Now, whether it's actually just age, or it's comorbidities is called, which of course are highly correlated with age. Older people have more comorbidities than younger people. It may not make a difference in a social sense, but it's not clear whether it's age itself or the concomitant increase in chronic disease burden in these other populations. So I think, I don't know. I mean, one of the issues that we're now addressing here is everybody wants to, is sick of the lockdown. The population as a whole is sick of it, or many people anyway. And businesses, of course, want to get back to work. The government wants people to get back to work. They want the economy to get going. And so the patience with the lockdown is declining rapidly. And I heard last night that all 50 states are now starting to relax their lockdowns in different ways in different places. And, that's quite worrisome to epidemiologists because they can see that, by far we haven't reduced the number of susceptibles and people who haven't had infections and therefore potentially immune. Those are not reduced very much, maybe 1% or something like that of people who've been infected. So still 99% of the people can be infected. So we're getting and without the protection of social isolation, which has worked fairly well, we maybe see a big second wave. Now, as I was saying, the only analog we have to this pandemic is the Spanish flu, so-called Spanish flu in 1918. I say so-called because wherever it started, it didn't start in Spain, and that was just the rumor that got started at the time. It's interesting how rumors sometimes get embedded in history. It probably started in Kansas, actually, but it may have started in China, but those are the two most likely places. In any case, the Spanish flu was the worst pandemic, arguably, in human history. It killed 50 to 100 million people. And of course, the U.S. got to reacting to it late. It was mainly the efforts to control it were mainly at the city level. So some cities locked down early, some cities locked down late. There's a famous story of two cities, Philadelphia and St. Louis, where St. Louis locked down early and had a very mild first wave. In Philadelphia, waited till after a
major event, right? Like a parade or something?
St. Patrick's Day parade, yes. Yeah. They couldn't withstand the Irish influence, I guess. Anyway, they had that parade and they had a terrible first wave. On the other hand, St. Louis went off their lockdown, after 8 weeks, because they couldn't, withstand public pressure anymore. And they had a terrible second wave. So again, it's somewhat a different world, although it was America, and it's certainly a different virus. But I think there's some lessons there. I mean, so the worry now is if we come down off the lockdowns too fast, too far, we're going to be in big trouble. And normally this disease, almost every disease has some seasonal pattern. And flus, this is not a flu, but flus have this odd, some people think it's odd pattern of becoming less a problem during the summers, and then coming bigger problem as the cold weather sets in. And it's not thought to be actually the temperature affecting the virus itself. As seen in Brazil, it's a hot country, but they're having a terrible time, and temperature isn't helping them. But that the temperature affects people's behavior. And in the summer, of course, people are spending more time outdoors and so forth, and there just may be less chance for transmission. I guess we're going to learn that this summer here. But in the fall, we're going to go, likely there's a real concern for the second wave.
Can you, oh yeah, I was just gonna say, we couldn't see half your face there as you were closer.
Okay, so,
there we go.
and the other thing that will in the fall happen, we know, is that we'll get the flu. The flu, which is still a big problem in the world, it's bigger some years than others. This year, this last year, the 2019-2020 episodes of the flu, we had a pretty bad flu in the United States. I don't remember the exact number. I think 60,000 died. But there have been years in the past. In 1958, I think there was one, and there was also a terrible flu epidemic in 2015 in Europe. So it'll come in the fall. We know that, and it may compound this COVID infection, which is an entirely different virus, but they act on the same people. And one of the lessons on the flu side is that we do have vaccines for the flu. They're not 100% effective, unfortunately, but we do have them, and they do make a difference. They do work partly, but many people don't get that vaccine. And that's partly because there's the anti-vax movement, people who mistakenly think vaccines cause autism and other problems. But it's mainly, I don't know what it is, laziness or people not paying attention to their doctors or whatever. They just don't bother to get the vaccine. So once we have a vaccine for COVID, will everybody take it? That's a question. It's a behavioral question. A lot of these issues come down to the behavior. If you lock down completely and you do it for many, many weeks, it makes a huge difference. And we know this is the case because other countries have done it well. Latest example is New Zealand. New Zealand has essentially cut off this epidemic. Now they have the advantage of being an island, so they can stop import of infection. But Korea knocked down the infection almost entirely. Taiwan, Singapore has done well. Even China itself has done fairly well given its size through a very effective lockdowns and people, complying with it, wearing masks when they go out, staying at home, so forth and so on. And Americans, I'm an American, we aren't known for, this kind of compliance, at least over long periods.
Yeah.
And the Spanish flu, again, our only other example, some cities only lasted 6 weeks, some went 8. No city in the country went past 11 weeks.
Wow.
And we're coming up to 11 weeks here. And, so that is a problem. Now, personally, I don't think you can get a population to be locked down forever. We may have reached the limit, but when we come off of it, we have to develop ways to be more protective and say, people say, get back to normalcy. It won't be normalcy for a long time. But in workplace practices, I know you have business people listening and wanting to know how to organize their workplaces, put in barriers and require masks and cycle through shifts so that there are not so many people in one place at one time. There are a number of things that have been worked out to reduce the transmission at the workplace. One of the main interesting things about this is something you referred to is, will the world go back to being the same as it was at the beginning? Or, and there's evidence for this, unfortunately, from the Spanish flu. I mean, basically, the world went back to be the same as it was before. People didn't even want to talk about it. There were no books, there were no articles. And, if you look at the literature in the 1920s, nobody even talked about it. It wasn't until decades later that historians went back to look at it. And there's still books being produced about the Spanish flu. Will people be like that? It'll just be a little episode nobody wants to talk about. Or will it change fundamental things in society? I mean, greenhouse gas emissions have gone down largely because fuel consumption, people are burning less fuel. Will people go back up to burning the same amount of fuel, or will it somehow change? I have many colleagues who would like to think this is a moment in history when we can make a change going forward. And I'm a little cynical about that myself. I mean, partly because, and it's very hard to talk about this epidemic in the US without bringing in politics, I'm sure, but the Trump administration is busy dismantling environmental regulations, and the argument being it may help the economy come back faster, but they were dismantling environmental regulations before the pandemic, and they're just dismantling more of them now. So that may come back worse. The economy may be worse for things like environmental protection afterwards than before. Some things, on the other hand, I think will change. I mean, but these were things that were happening anyway. For example, doing things online, teaching online, working online. I think many more businesses have gotten used to people working from home and find it more acceptable than they used to. They were just like universities were a little reluctant to get into it because it seemed different than in the past, but we've now learned, at least here at Berkeley, we've learned you can do a lot of good teaching online, and maybe some modification of things, but I think that'll accelerate that movement. Maybe even the socializing online. I have cocktail hours with friends now, virtually, on the Zoom. I think we'll do that in the future. Some things that I say were coming anyway, and partly because of the IT revolution, we've been.
Hey, Kirk.
Yeah.
Quick question. Do you have another slide, or should we take the screen sharing off?
Yeah. So I do have another slide, but let me. I'm going to go off this, and so there was another issue I thought that people, this group might be interested in, and I will now raise that, do that one.
Okay.
So, sorry, you got a professor on the line who does nothing but talk. So, you can please interrupt me.
No, it's great. I mean, it's great to hear you talk.
Please let me interrupt me if I'm not getting to some things. So one question is, let's see. I want to get. So what about the impacts of the economic downturn, not of COVID itself? Now, a little bit hard to separate the two since they're happening at once, but we can, work is being done to try to separate the two. And, there are reasons to think that the improvement in health, health is my metric here. So the economic downturn, we know that it's stressing people a lot, and people lose their jobs and they're worried about getting them back, and the homeless and the poor, can't get access to food, although the government has, been trying to provide some relief. Air pollution exposures, but there are, I think, positive things about the turn down in the economy. Air pollution exposures go down. Traffic accidents go down. There's been recent data out of the National Safety Council that showed that there were 10% fewer traffic deaths in March compared to the year before. Industrial accidents go down. On the other hand, access to healthcare may decline, particularly if all the beds are filled with COVID patients, including mental health care, access to food, and so forth. So what is the net impact? What is the net impact of the economic downturn? Trying to separate it from the pandemic itself, which of course has a terrible health impact.
Yeah.
Well, we can look at the health impacts of previous economic downtowns to learn about this. Let's examine the biggest economic downturn in the modern world history, the Great Depression. So my question is, we've all seen the impact of the Great Depression on the economy, but what about the impact on the health of the population? Huge impact, bigger impact than even now with us. And of course, extending over years in the Great Depression, and without the social safety nets at least put into place early, like here. What happened? It's quite interesting. Now, these are European data. First, I'm showing because data are better in Europe at that period. Here's the Spanish flu. Look at the terrible impact. This is life expectancy during the Spanish flu. And here's the Great Depression right there. Almost nothing. In fact, it's a little, not even a statistically relevant blip. It had apparently no impact on long-term health, in spite of the huge impact it had on people's lives, economic lives, in Europe as well as the US, as you know. Now this is Europe, maybe, we can look at the US. And here you can see them for males, a huge drop in life expectancy among males who were hit harder than women by the Spanish flu. Here's women, there's men. And then here's what happened during the Depression. Nothing. There's the Depression, this deepest part of the Depression right there. The black line is the actual data. This is the uncertainty bound around it. Well, within conceivable uncertainty bounds, maybe at the high end. Actually, the evidence is that health improved. Not clear. It certainly didn't. There's no evidence that it got worse. Now, let me emphasize, this is the average person. It's not, maybe special groups, Native Americans or Black Americans, suffered much worse. But this is quite interesting, I think, that the Depression, a huge economic impact, didn't have a major impact on health in the country.
Quick question, Kirk. If you go back that slide, showing the drop around the Great Flu. What about World War I? Was that factored out?
No, no. I mean, World War I didn't have much of an impact in the U.S., as you know.
Of course. These are U.S. numbers. Yeah. What about the European numbers?
The flu killed far more people. I think you can see World War I here in the European data. But now let me, what are the explanations here? Well, fewer traffic accidents. That's definitely the case with us now. It certainly was the case during the Depression. Less air pollution, although air pollution, the health effects from air pollution usually take longer to improve than, in just a month or two.
Yeah.
Less income means consuming not only fewer good things, like high quality food, but also fewer risk conferring things, drugs, tobacco, alcohol, gasoline, and so forth. And there is evidence that those particular risk factors are going down. Fewer workers exposed to fatigue and occupational hazards, including work-related driving. These are just some of the hypotheses.
Yeah.
Fewer workers who fear layoffs reduce behaviors that put them at risk of layoff, including alcohol use. Mental health and suicides do go up, but the evidence is that it's a harvesting effect, is it moves the suicides earlier than they would have happened. The people were, mentally depressed or unhappy with their lives anyway, and it just sort of triggers them to commit suicide. But it doesn't create a new group of people wanting to commit suicide. And these are the hypotheses. So now let's look at the other side, the impact of the Great Depression on the GDP, or on the economy. Huge hit, as you can see right here.
Yeah.
And of course, stayed low for quite a while, and then or lower than the trend. And then we got the big benefit, if you would like, that want to call it that, of World War II. But notice it had no impact on the trend. The same improvement in the productivity growth and all technology and all the things that affect GDP continued after these two big hits, negative and positive, if you will. Positive, World War II being a positive hit on the economy. And look at this. No change. So, what's my conclusion from this? This is actually work done in response to our president's statement that the cure is worse than the disease. No, I mean, the disease kills people and then they're dead. But the economy does recover, is our experience. Now, again, this is averages. Doesn't mean that, if you're poor and on the edge, that you're going to recover suddenly. So this is a big argument for, well, exactly what the country has tried to do with these, the CARES and relief package, with all the things done, the New Deal that was done during the Depression. You maintain the floor so that, people don't go off the edge of the cliff because of the economic downturn, but the economy will come back. Or as an economist friend of mine says, we understand economies a lot better than we understand, pandemics. We can, we know what's necessary to maintain the floor on the economy, to invest in industries and innovation and tax structure and so forth to bring economies back. That we've had a lot of experience with, although I must say, as a non-economist, I wouldn't say that how the 2008, 2009 downturn was handled. It made it seem like they were all that expert at it. But anyway, we came out of that okay, I guess you'd say. And so I don't know if that's something this group who's more tuned to the economic side of things would agree to, but that I think they would agree that if you die of COVID, you're not coming back. And what you want to do is not let people be so damaged by the drop in the economy that they can't come back. But if you keep them going, they can come back, as we've seen, even in a worse situation in the Great Depression. So those are the 2 points I wanted to make about the distribution of deaths with age and more data we have on that and how it affects, in a sense, each of at least of our cohort, our age group in general, may not necessarily ourselves, and the fact that great drops in the economy don't seem to affect health in the long run, and they don't even affect the economy in the long run.
Well, it's provocative and interesting. I have to say, I read pretty widely and I haven't seen that analysis, and I appreciate you bringing that to us. Glad
to try to answer any specific questions. A lot of those questions I say, if we, I don't know, we had Albert Schweitzer or something available, maybe tell us.
No one can say, but would love to hear your thoughts. So tactical questions about workplace safety, just a few that I want to throw out. Do you recommend using fans like in a workspace with open windows?
Well, let me take that in a broader sense. And I noticed the CDC came out yesterday, and finally, I would say finally, but I said the right thing. I think that this disease is not, it's not by touching your mail or food packages or something like that. It's mainly airborne, mainly breathing it. So not entirely, but you saw those scenes of people walking down streets in hazmat suits, spraying everything. I don't want to criticize that. People feel they have to do something, and that is something to do, but it wouldn't have much impact on things. So cleaning workplaces every half hour, with alcohol-based things. I personally don't think that's a big now. It's always a difference. If you're working in a healthcare setting where you've got a lot of COVID patients around, clearly you have to clean things. But in a normal workplace, or walking down the street, or taking your mail from the mailbox, or picking up the Amazon package, it's not worth it, in my opinion. And CDC kind of backed that up yesterday based on the data. So this, that gets back to your question. So what do you do in workplaces to make them safer? Well, you maybe clean them once a day, but I wouldn't go around cleaning them every half hour. You need to make sure that the air is well, circulated, and of course you won't have any known hotspots of COVID patients like you would in a hospital. So you don't treat one area differently than another. And so you do need to make sure that people are not exposed to the breath of somebody else. And that probably, some workplaces are pretty dense. You would need move the desks further apart, and maybe require masks if there's any kind of congregating, you know, coming in and out of the building, for example, through the elevators or cafeteria or whatever. I mean, it's just a matter. I mean, and it's not nothing's 100%, but we've seen in the case of you know, these other countries, and I would say even in the case of these 6 counties I live in here in California, very good social distancing is able to turn over the curve.
Yeah.
And so we need to continue to do that. This disease is not going away, and we don't want this coming back to us and haunting us in the middle of the flu season in the fall.
Yeah. What do you think about like using fans with open windows, revamping HVAC systems?
Well, I think you know, you know, outdoor air is going to be better than indoor. That's for sure. I mean, which is not always the case. You know, sometimes there's air pollution.
Sure.
It's just the time to worry about pollution.
Yeah.
And somebody, I didn't ask a question about purifiers. You know, there are air cleaners for smaller airspaces that would help in this regard. And it's, you know, I say it's airborne mainly on droplets, you know, which can be small, but still not so small they won't be picked up by air cleaners. So if you really have a workplace where you're worried about, you know, you have to have, for some reason, several people in a space, you would normally not want them to be so close together. Yeah, put an air cleaner in. And change the filter, because one of the things about those air purifiers is they don't work forever. The filters have to be changed, and so just put in your budget, and often the cost of the filters is greater than the cost of the gadget. Yeah.
What about accurate sources of information? What do you recommend?
Well, you know, this is now, what did Warren Buffett say? You know Warren Buffett. He said one of his famous quotes is, "When the tide goes out, everybody can tell who's been swimming naked."
Swimming naked. Yep.
And you know, unfortunately, you know, I mean, this has been, you know, I don't know what you call a revelation or a real shock to many of us in public health. Is, you know, our golden light for decades was the CDC, but unfortunately, they've lost a lot of credibility. I mean, because of cuts in the budget, because they fired the leaders. I mean, then we know why, but it's unfortunate. And so I think there's still good things that come out of there. So, I mean, it's still the best source of information, but just not as, you know, proactive as they might be under a different White House. So I would still watch the CDC, and also NIOSH, you know, your workplace organization, I mean, focused on workplaces. NIOSH is still the leading organization. You know, in some states, our state, for example, actually have their own, you know, versions of these, and could give out good information. So, I mean, you know, one of the problems, and it's certainly evidenced in Spanish flu as well, is all sorts of crazy theories get proposed. You know, that Spanish flu was, you know, wasn't Drano, but, you know, drinking lots of lemon juice or anything, you know, whole range of things. And so, you know, forget all of that. You know, look at the, you know, I still think the government basically is the right source. And I think New York has very good agencies in that regard. They also, of course, pay attention to the CDC for you. So I would say, you know, if you had to only look at one place, look at your local health agency.
And what about personal travel this summer? Would you say don't do it?
Well, I mean, there's travel and there's travel. I mean, I might not go to in the middle of Brazil, but it's,
what about getting on an airplane? Would you?
I would say, you know, interesting question. You know, here I have a very close friend and colleague who's a physician, a pulmonary physician. He works at a hospital in San Francisco. And they were, you know, they called in all the troops, and, you know, they stopped all elective surgeries, and very few people were coming into the hospital because they were afraid of going to the hospital. And so they actually had a quite relaxed, you might say, COVID experience. I mean, they didn't come anywhere near to overwhelming their capacity. Oh, they might have if the surrounding population had not, you know, carefully socially distanced.
Yeah. But
they just didn't sit there. They actually sent their extra physicians, their extra nurses to New York, which is the right thing to do. Now, those particular people are back now because New York is now, past the peak of its problems, but they did get their system overwhelmed, but they did get help.
Yeah.
So people all over the country sent, and of course, it's not zero risk at the airport. My understanding from talking to them is that their flights were quite nice. I mean, there were, every other row had a couple of people in it.
It's a little more full now because they've cut so many flights.
Yeah, so they still have flights, at least to the major places, and wear a mask, so I guess if you have a reason, I think it's getting more. The risk. It's a risk-benefit calculation.
Sure.
If you're, need to go to a funeral of a special person, or your mother is dying, or whatever, go. It's not the time in the U.S. Now, foreign travel, a bit different. Now, one of the things I don't understand, actually, is the why so little temperature testing is done in this country. You see in other countries that you've got these guns, you point it at the person's forehead, and you can instantly detect their temperature. They're not perfect, of course. But in China and Korea, and even I've seen in Europe, people are getting tested all the time.
Yeah.
You don't see that
here.
We
should do that.
It's not at the airports. I don't think so.
I think the airports. I think the TSA is about to start doing it. I think that's
they should. I mean, again, it's not perfect. I mean, none of these things. You don't want to. The good shouldn't be the enemy of the. The perfect shouldn't be.
Yeah, because of course that doesn't capture asymptomatic or.
Yeah, sure. It's not perfect, but at least again, it's another notch down the risk ladder for you.
Yeah. What are the behavioral changes in your, analysis that really matter, like face masks, social distancing, temperature checks? What?
Well, we haven't done temperature checks here, but so in any kind of systematic way. And the things that everybody should wear a face mask out in the public now. One of the issues in my field is that we've looked at face masks for decades. We have systematic methods of testing them and so forth. And a cloth mask kind of thing you see people wearing doesn't really won't protect against air pollution, for example, but it does. Its main effect is to protect other people from you.
Right.
If you're asymptomatic, for example.
Yeah.
And also is a symbol, and more than a symbol. You touch your face less when you got a face mask. You're sort of more aware of things, if you are. So, and I have colleagues in China who just finished a massive national survey covering 31 provinces. I think there are only 34 provinces in the country. And they found that 93% of people they watched on the streets were wearing masks.
Wow.
Now, what is it here?
I don't know. I'm in New York, and it's not that. I would guess we probably have more in New York than anywhere else in the country.
Well, that's right. I mean, and the same here. I mean, we see maybe my wife and I walk every day, and we kind of keep count. It's about half.
Yeah.
And so that's a behavioral thing that could be improved. I don't know how you improve it. I mean, it's culturally much more acceptable in China and Japan than it is here.
Right.
Even in non-pandemic days. So how you change culture, God knows.
Do you recommend getting a COVID-19 test or antibody test if you're asymptomatic?
Well, I mean, okay, let's talk about antibody tests.
Yeah.
I mean, one of the problems in the media was, I think they've improved recently with the stories in the last couple of weeks, is, this test is a test is a test. A test is not a test. A test, there are dozens of tests. They all have different characteristics. Many of them are not well validated. They haven't been tried in real populations, they're lab-based. And so actually on campus here, they've jointly with UC San Francisco, they've created a COVID-19 testing project, where they're testing all of the tests. These are focused on the
tests.
tests.
Yeah.
And I tell you, they're miserable.
Oh my God.
So
really?
I mean, and so
is there anything that's good?
No, I mean, part of the problem is the basic science that we don't even know if you get immunity.
Right.
Not even clear.
Of course.
This is a coronavirus, and the common cold is a coronavirus. How much immunity do you get from a common cold? 2 weeks maybe. You
Yeah.
can get 7 colds a season.
Right.
If that's the way this works, we're in a hell of a mess.
Yeah.
Or it acts more like a flu, where you get a year or 2 years worth of immunity. The only thing we have to go with, as an example, is SARS-1, the first SARS epidemic. This is SARS-2, the official name. That lasted 2 years, immunity.
Hmm.
So that would mean that if eventually we get a good vaccine, it's not going to be like smallpox. One shot,
You're done. It's going to be every 2 years.
Yeah, it's going to be every 2 years, or maybe every 1 year. I mean, it's so we don't know that. So that's one of the problems. What does immunity mean? I mean, even if you have it, it maybe lasts 2 weeks. I mean, and then in addition, there are thousands of antibodies in your system, anybody's system. Which of those are the best ones? Which, 5 or 6? You tell me. I don't know. They don't know. And then you have the standard problems with testing is a huge amount, the amounts of false positives and false negatives.
Yeah.
And many of these new tests, I mean, some have very high false negatives, some have very high false positives. So my expert colleagues who work on this saying we're probably going to have to institute a protocol of having several tests, because you can improve the likelihood of a correct positive as opposed to a false positive.
False positive, yeah.
If you give multiple tests. Right. And the Chinese give 3.
No, I did not know that.
Which doesn't seem to be well reported. I mean, I heard a lecture by the head of the Chinese CDC last week, and they're giving 3 as the standard. So the testing, I mean, bad enough. I mean, with the PCR tests that measure whether you're infected at the moment.
Right.
Immunity tests are a long way before. No, so I mean, I should back up. My colleagues would tell me I'm saying it wrong. I mean, it's the thing about immunity tests. They tell you about a population.
Right.
They tell you whether a population has got has been infected in the past. They don't tell you almost nothing about an individual. And most people don't understand that. They want to know, am I immune or not? Right. Well, you can't say that. Even if we understood that the immunity lasted a while, we couldn't tell you because the tests, because of the false positives and false negatives. And so, it's good for a population analysis, which is valuable, So I'll tell you one thing that the campus is doing is we're thinking of emulating what goes on in Switzerland, France, and Belgium, which is to measure sewage systems. You measure wastewater, and because we know that the virus is shed into wastewater, and so you measure the sewage system in a dorm, and you can't tell who in the dorm has been infected, but you can tell whether there's an outbreak occurring. That's really all the best you can do anyway. So, or another approach is to combine the blood from 20 people and test them once, and do the lab testing once. But that's not that much cheaper. The sewage system testing, you could do it every day.
Right.
There's no intrusion. You don't have to bother the students, and you only have to do 1 lab test. I mean, I think we're going to see a lot more of that. And in Europe, they use them for surveilling the whole community. We're planning to use it for surveilling the dorms. So there are some tricks to get more out of the testing, but it's, some people, early on in the pandemic, people talk about immunity passports.
Yeah.
That those would be the people you'd want to hire for a job.
Right.
Well, I don't think there's going to be, the science isn't up to doing that. The testing is just not possible to assure that. Maybe, my colleagues say you get a sequence of 3 of these tests, and they have different, some are high false positives, some are false negatives, and you sequence them correctly and analyze it. You maybe.
Okay. If you could wave your wand, Kirk, what would you recommend we implement to minimize the risk right now? You would keep the lockdowns going?
Well, it's one of these things. I mean, if I had my preference, nobody would smoke. But that's
me too. Yeah.
I mean, being realistic, I don't think you can lock down the society forever, and so you have to unlock down, whatever you call that, relax things in a smart way.
So face mask wearing.
Yeah, face mask
Everybody.
wearing, changing the workplace in ways
Set
that
up. Yeah,
reduce transmission. Temperature taking, sending people home if they, have, that
right.
spike of temperature, um, and so on. And then, of course, the public health answer is tracing.
Yeah,
Actually, every time you find a positive case, you go trace everybody who that person connected with, and that's another part of the secret in Korea is they did amazing tracing, and you can use cell phones and IT to do that
yeah,
these days. But it means, one of the questions that comes up in Korea, they could actually require people to be quarantined.
yeah.
I'm not sure you can get away with that here.
No, not with privacy.
You can ask them,
Yeah, right.
but so remains to be seen. I mean, that's why it's partly it's the belief of the public that drives the effectiveness of the social isolation. And if the leaders, unnamed leaders, are poo-pooing the whole idea, it doesn't help.
Can you talk a little bit about the vaccine research process and?
Well, the vaccine research is, last count I saw was there 106 vaccines being, worked on around the world, and of all different biological types as is appropriate. But I think people don't. I mean, I think it's been said in the media. I think even Bill Gates had a nice interview about it. I mean, if we developed a vaccine in 18 months, and let's say that would be what's the start date? The start date, I think, scientifically, is the moment they sequence the genome for this virus.
January.
About February 1st or so, late January.
Okay.
Yeah.
Yeah.
So 18 months from then, that would be the fastest development of a vaccine in human history. Now we put a lot of effort into it, a lot of people working on it. So there's, but there are certain aspects of the development that it can't be speeded up. Others that can. Main ones are the human testing. You've got to, make sure you don't die when you take this vaccine, and then it works. And how long does that take? I mean, there are some ethical issues that are coming up. One of them is, what do they call it? It's a different type of trial. Rather than, vaccinating a population and waiting to see who gets COVID and who doesn't, you actually purposely inject people with COVID. I mean,
Challenge tests, right.
Challenge tests, yeah, which is ethically questionable, but I'm sure you'd get volunteers, but even so, it's ethically questionable. They may approve those. If they do, it'll go a bit faster. The big issue is, of course, once you have a vaccine, then what? You've got, a few vials in a lab somewhere. You've got to get, God knows, 7 billion doses.
Right.
And get them out to people. So they're actually, Bill Gates, Gates Foundation and Wellcome Trust and the World Bank and a number of other deep pockets have created a fund, and they're actually planning to build vaccine factories before the vaccines are approved.
Right.
Because each vaccine require a different kind of manufacture.
Right. Right.
And so they'll waste some money, but they'll be better able to get going once they have one.
There's 26 million first responders in the U.S., for example, that would be first in line for a vaccine.
Yeah, sure. Then they'll be sequencing by priority and by whose brother-in-law they are and all sorts of things. But
for sure. Can you talk a little bit about hotels and large buildings that use elevators and have air conditioning? Like, what's the solution there? Are there better air filters or? Well,
there are better filtration systems, basically. You want HEPA filters for knocking down particles, but as I point out, maintenance is an important issue. I don't know exactly how elevators are ventilated. There's a point in which a lot of people are together, fairly close together.
Yeah,
it'd be a long ride, but generally they're shorter rides. It's interesting that UC San Francisco, which is created along with the city, probably the best tracing service so far in the country. Other places are starting to do it. They've had to define what they mean by a contact. If you just pass somebody on the street, no, it's not a contact.
Okay, good.
Even if you are in the same grocery store at the same time with somebody, it's not a contact. They've defined a contact. It's partly a practical question, but is being within 6 feet of somebody for more than 5 minutes. Now that's not all, I'm not even sure an elevator would do that, but it might. I mean, so maybe you would have to, have a system for only 3 people on the elevator at a time and only with masks.
Right, yeah.
I mean, that can certainly be done in big apartment buildings or business buildings,
Yeah.
but it would slow things down. It's going to be less efficient in many ways, our life coming up. A big issue for us and everybody's got issues with universities is, we're expecting 45,000 students to arrive back here in August. They're going to ban Super Bowl games, but that's like a Super Bowl game, right? 45,000 kids coming together and not just for 3 hours at a Super Bowl game, it's for months.
Right.
And this worries the parents, of course. It worries the faculty, but it worries the parents. I mean, they're saying, what are they sending their kid into?
Right.
It worries the city of Berkeley, of course, 45,000 people coming from all over the world.
Yeah.
So, I mean, we're a business in a sense. So what do we do? The campus has not actually announced the full plan, but it's going to be some component of hybrid approach. Some classes, the big classes, will have to be online.
Yeah.
And the smaller classes that can be spread out in a classroom, and still be distance, will probably be on campus, but they haven't told us at least how big those classes have to be. Another issue is testing. Do you require all the students to come with a proven, test that don't have the virus? What do you do if you're coming from France or China or whatever? Or do you retest them when they get here?
Yeah.
But then, you could be negative at noon and positive at night. You test them every week. How do you do that? What's the logistics? What's the cost?
Yeah.
And it's like a business. I mean, and it's a different one, of course. And then there's the financial side of it. I mean, if your kid has been accepted as a freshman at Berkeley, and he has to stay home, and you're paying what you consider a lot of tuition just to have him sit in his bedroom and watch TV all day. I mean, it doesn't sound like not the university experience that we were hoping for. So nobody knows.
So a couple more questions, and I wonder if do you have 1 or 2 minutes, or do you need to go?
I'm fine, yeah.
Okay. 2 questions. Someone's asking, is California trying to move toward a sampling approach where true incidence in various parts of the state can be determined through proactive randomized testing of residents?
Yes. The answer is yes.
It is. Okay. And can you say more about that?
Well, I mean, I think it's a fairly, I'm not an expert in it, but there are some mathematical models that show you if you do so X amount of testing, you can catch an outbreak within a certain length of time.
Okay.
You may have to make a decision how long that length of time you want
Right.
to. You can't test everybody every hour, but
Right. But and the state of California is moving to.
Yeah, they're moving in that direction.
Okay. Some universities are starting classes in the fall. NYU, interestingly, announced they're going to have live classes on their campus in New York City. At least they said that last week. Cal State, the biggest public system in the country, your University of California, Cal State said they're not.
Right. For
those faculties and students that will be in person, what measures do you recommend? This is a parent, I think, asking for her kid.
I don't. Universities are caught in a real bind. I mean, our university has dealt with this by postponing the decision. But
yes.
It's not because they're procrastinating, it's because they want to have more data. But they have to, people have, in mid-June is, I mean, the usual time, to admit people and they have to confirm their coming is May 1st. So giving them 6 weeks.
Right.
But then they have to tell them, what's the experience you're going to come for?
Right.
And, but fully open. I mean, I don't know what they're planning in terms of maintaining social distancing. That would be the concern. One of the issues that people don't talk about is the liability. In most states, state universities can't be sued, but private or, you know, so Stanford, our friend down the peninsula here, you know, if somebody sends their kid and he gets COVID, I mean, they can be sued. At least now, and I understand they're trying to put through legislation to you know, shield the private universities from suits as well. But that, you know, there's some legal issues here too, and also, you know, people, you know, like the bars and stuff. You get news items coming up that a bar is opened up somewhere, contrary to the local recommendations. They can be sued if they're not meeting that, you know, the public health norm. That's the risk they're taking.
Oh, so Tesla could be sued if one of those workers got sick since they opened earlier.
Yeah, well, unless they get, you know, official dispensation.
Although I think they did end up getting an official.
I think they did. Yeah, they wouldn't. I wouldn't think they'd go without that. It'd be huge, you know, liability.
Huge liability. Yeah. All right. If just a couple more questions, can you talk a little bit about India, Latin America, Africa?
Yeah. So, you know, I've been to India, I think 140 times, and first year. Well, I was there in January, so I can't say it's the first year of not being there, but it won't be there the rest of the year. So, you know, it's as I say, you know, the 100 million people that died of the Spanish flu, 50 million were in India.
50 million. I don't know if people, because that was before we talked. I don't think people realize that half.
Yeah, so it was a horrendous thing. I mean, you know, there are accounts, you know, often colonial, you know, accounts, because it was a colony in those days. You know, bodies lined up in the street, piled into big piles. I mean, you know, terrible things. So, you know, India's, you know, different than it was then. This is a different virus. It's better developed, but it still has, I don't pick your number, 700 million people living in, you know, poverty. And one characteristic of that is it's slow to move into rural areas.
Yeah.
So it hasn't had, you know, one of the questions I'm asked all the time is, why is Brazil suffering so much and India suffering so little relatively, and so far? And I say it's mainly the so far. It's, you know, so it's one bit of evidence. You know, some people say, well, because it's hot in India, it's not going to happen. Well, it's, you know, it's hot in Brazil too. So I mean, it's, you know, I think that's pretty well discounted. You know, and then there's these issues you saw even in Italy with a very well-run healthcare system compared to most by far. They missed so many of the deaths.
Yeah.
Well, you know, people die out in the middle of nowhere in India, and, you know, even in the best year, and they're not. I mean, it's part of an effort called the Million Death Study in India, run by colleagues out of Toronto, and they actually did autopsies of 1 million deaths, called verbal autopsies, where you go back and interview the family and local people and figure out what the person died of. They capture the deaths, but they don't capture very well what they're caused by.
Yeah.
And when they actually did these verbal autopsies, they discovered new things. One of the most interesting to me was, it used to be thought there were 6,000 snake bite deaths in India every year. They now think there are 50,000.
Holy.
And so, you know, we'll be doing verbal autopsies on deaths in India, you know, in the future to figure out what happened. Yeah. So and we'll put it another way, they haven't been doing much testing, and of course, so we don't know really what's happening.
What about, do you happen to have any knowledge about Nigeria? Same population size as Brazil, about 200 million. Is it underreporting?
Well, you know, the first thing I know, I haven't looked at the Nigerian data. I'm sure it's vastly underreported.
Yeah, yeah. And then data in the United States, it's, I think it's very messy, isn't it?
Yeah, it's messy even here. I mean, you know, if you wanted to look at good healthcare systems, you're more like looking at Europe. Actually, China has, in some ways, a better reporting systems than we do. So now, only recently, but Europe probably has the best. So, yeah, I mean, I'd say we're probably greatly underreporting, particularly at older ages. You know, I mean, Trump was right in this case. The more you test, the more cases you find, but that's, of course, what you're looking for. And we haven't done enough testing to sort of, you know, create a steady state understanding of the cases. The COVID deaths are just those have been defined, you know, and diagnosed as a COVID case with a test at the time, but there are a lot of others. I mean, I have a good colleague medical colleague who believes that in the end, the biggest death toll will be non-COVID cases. You know, people who couldn't go to the hospital because the healthcare system either were afraid to go or couldn't go, and for therapy for cancer or stroke or whatever. So
yeah, that would not have happened during the Great Depression, for example. If it's just an economic calamity, you're not going to have people not going to the hospital for
those reasons. Yeah, right. So
yeah.
Our problem in analyzing this is they're happening on top of each other. So.
That's right. Yeah, it's so difficult. Well, I think that really ends up addressing most of the questions. I just want to look and see if there's any other. Just one last question. Let me ask. I guess the question that you can't answer. How long is this going to last?
Well, so. Assuming what? I mean, assuming a vaccine is developed and it works, and it gives you, at least a year or two immunity.
Yeah.
We're talking about maybe starting to vaccinate people in large numbers late next year.
Okay.
And that's when it starts to end.
Okay.
But we're going to be coming back to work a lot before then, coming back to school and so forth. So we're going to,
So there'll be waves.
Yeah, right.
And in your opinion, would you say, near 100% probability there's a second wave?
Yeah.
Yeah, that should just be expected. Looking at all the data that the way we know this works. Yeah, that's not controversial for you.
No, it's not controversial. It's just how big it'll be.
Yeah, yeah. Well, thank you very, very much. And everybody stayed longer. I think it's such an important topic, and it's really helpful to have your time and insight and your access to your expertise. Really appreciate it, Professor Smith.